It looks like we're slowing down here. Nicole, did you want to get started?
Yes, I can. Oh my gosh, I haven't. Let me close some tabs because it's kind of scary and I don't think everyone needs to see uh the actual 10,000 tabs I have open right now because honestly it's kind of frightening to me. Okay, and then we can share this. Let's see. Um, here we go. Start and then sharing. Oh, let me go back. Okay. No, I don't want to share my desk. Why is this doing? Okay. Is everyone seeing um my lovely Google Chrome screen?
Yes.
Oh, thank you. Okay. Um, okay. Should I put my video on? Oh God. Let me see. Hi everyone. Okay. So I know you have your exam next Monday. So we're just gonna walk through the some hand, wrist, elbow, loveliness. Okay. Lovely agenda we have here today. So we're gonna be talking like the forearm, radial nerve injuries, carpal tunnel, movements of the thumb, thenar, hyperthenar eminence, and then blood supply, nerve supply, snuff box, and Decker veins, tendonitis. All of this is super relevant. I promise. You see it every single day. If you work in sports med, um, family med, internal medicine, like orthopedics, it's the most common stuff you'll see just because of the um lifestyles and things of patients. So the superficial muscles of the extensor compartment of the forearm. So I think it's also really if you're having difficulty with kind of narrowing down or just like putting there's all so many muscles in the upper extremity, it's probably easier to do it by compartment or by function. So here we have laid out um the superficial muscles of the extensor compartment of the forearm here. And then, right, they all have the common origin site, which is the lateral epicondyle. Um, and the lateral epicondyle, as we'll later talk about, is right lateral epicondylitis. So that's like the extensors of the forearm. Great. So I'm not going to sit here and just read off all the extensors, but just kind of group them together and know that, like, okay, if you have an injury to your lateral epicondyle, the extensors are going to get affected. Oh, great. So we have a lovely slide. I didn't put a picture. I'm sorry. But so when you have lateral epicondylitis, a lot of times it'll be people who are playing tennis, which is like how it's got the name tennis elbow. And a lot of times these days it's actually nicknamed like pickle elbow or pickleball elbow because of the um great uptake of everyone playing pickleball these days. But it's from overuse of not overuse, it's like more of like just kind of like a degenerative tendon injury that you get. It's more common in like middle-aged people, but you can get it when you're younger. And it's just you get a really bad pain with extension and supination of the forearm. So to test that, a lot of times they'll do those motions against resistance. So they'll do wrist extension against resistance. And if you have pain, then that can be a positive test for lateral epicondylitis. Um, and then most times they'll just send you to PT and you'll be on your way. But it will be because of yeah, the extensor. Um, moving on to the radial nerve. Um, so the radial nerve does split, and then that is also the biggest innervator of the extensors of the forearm. So all those, most of those lovely muscles that we were just discussing, if say a patient comes in with oh my gosh, wrist drop, then there's most likely have been a radial nerve injury. And a lot of times it'll happen if a patient is has been like sleeping like on their arm all night. So like if they're laying on the top portion of their radial nerve, they also call it Saturday night palsy, um, because of the certain, I guess, clientele of patients that come through there. So they'll fall asleep after a lovely, fun Saturday night and wake up with wrist drop. But obviously, there's other modalities in which you can get it, but that just seems to be the common one. It is important to note, though, that the superficial radial nerve is just sensory. So although it splits, it's like I'm so sorry. I forget the muscle that it comes, the tendon that it comes right after. I'm sorry, everyone. If someone is able to help me with that point, but once it comes out, it splits and it innervates just the top, um, sorry, the dorsal aspect of the first few. I think we might have an image. I'm not sure. If not, I'll definitely pull one up. Um, with this,
Nicole, is that the collateral that it splits into?
well, when it's, I'm sorry, I don't know if I'm talking about when it splits, like when it's the superficial is down by the lateral, just like the distal lateral wrist. And it like comes out. I don't, you've probably seen it in lab and like splits like it's like right here. I'm so sorry. So like you have your wrist right here and it like comes out. Oh my gosh.
Nico, can I add something?
Yes, please.
Yeah, so Deborah, you said collateral thing, and when it comes to collateral term, that refers to artery. So if you see collateral recurrent artery of radius, I mean radial recurrent artery, that is anastomosis with radial collateral artery. But when it comes to nerve, then the radial nerve becomes superficial and deep when it comes to the cubital fossa area. So make sure to know the difference.
Thanks, Don. Great. So yeah, so it's definitely important. Make sure you know the different ones. Oh, look at that. I just skipped ahead. Oh, this helpful. Yes. So make sure you know like when it pierces and then it becomes the posterior interosseous nerve and then becomes the sorry, I'm like, I understand now when professors are like reading the chat while they're presenting. I can't do both. So I empathize with them now. When it goes through the supinator, becomes the posterior interosseous nerve, and then that portion is just, oh my gosh, why am I going forward? There we go. Oh my gosh, lovely. So does anyone want to answer this question? Lovely. Try while we've kind of preluded it a little bit. No. No. Okay. Oh. So this is the portion that the superficial branch of the radial nerve provides sensory innervation to. So this is, I don't, yeah, you definitely can't see like my mouse, which is fine. But if you see where like the red portion first starts on the wrist, like that is where the innervation starts. And it's also important to note that it does not do or does not innervate the tips of the fingers. So the tips of the fingers, like the backs of the fingers, will be by the the branches of like the median nerve. So that is also really important to note, because if, say, like a patient comes in, they're like, oh, like I have like on the back of my hand, you would think, oh, it has to be the radial nerve or the ulnar nerve, depending on what finger it is. But since it's the tip, that is not the radial nerve, and it'll be the median nerve, which we'll kind of get into more later. Yes, so the interosseous membrane is between the ulna radius, and that's just, we do that fun in OMM too, so look forward to that next year or later in the spring. So does anyone want to try to venture the
We have
different?
some practice questions next covering these
Yeah.
and too, if you want to go through the practice questions
Yeah,
too.
that works better then. We'll do that. Okay, so here's a problem, everyone. So 35-year-old construction worker falls, sustains mid-shaft fracture of the humerus. On exam, he's unable to extend his finger and wrist, and then sensory loss is noted on the dorsal surface of the hand, especially over the first dorsal web space. Which nerve is injured? Okay, so I see D in the chat. And yeah, if it was the tips of the fingers, it would be most likely a median nerve injury. I hate to say like all or nothing, but I know for like the sake of this exam and what we're doing now, obviously like there's probably people out there with just different types of, not different types, but like different movement innervation just because of their embryology or whatever could have happened. But yes, if it's the tips of the fingers, it should be median, depending on the fingers too. So if it's like the first 3.5, median, and then ulnar does the other sides. I hope that cleared that up. And then good job to whoever said D. Ulnar would be the fourth and fifth digits. We'll get into ulnar nerve, I promise. Sorry. Okay, here's another problem. 42-year-old tennis player presents with difficulty extending her fingers at the MCP joints, but wrist flexion is preserved. There is no sensory loss. Which nerve is most likely affected? Okay, so we're going to move on. So yes, it would be the deep branch of the radial nerve. And yeah, since, as Ashley Lovely put it in the chat, as since you're unable to extend the wrist and the fingers, that's really key for radial nerve injuries. Yeah, we can go over the other options. So a median nerve injury, median nerve would be that's part of the flexor compartment and oftentimes would result in carpal tunnel syndrome. And there's also Ronator Terry's syndrome, which would again, not be on the extensor compartment. So I think that every time you see an extensor motor problem, most times just think of like the radial nerve, because that is that really, I just think radial nerve is basically all of your extensors, right? Median nerve is going to be covering flexors, and it's going to be sensation loss to the first 3 digits. A lot of times it's when people are doing like repetitive, like typing, crocheting, those types of tasks. And it can also be like from sleeping. But and then the superficial radial nerve, if that was the nerve that was injured, it would only be a sensation loss. And there was no sensory loss in this scenario. And there was also motor deficits. So superficial radial nerve wouldn't be a choice there, since you would need sensation loss. And then ulnar nerve, I think it's more difficult to do like those really fine motor skills, and abduction and adduction of your fingers is really weakened. A lot of times I think that ulnar nerve injuries have motor problems that do result before sensation loss, although that's not like an end all be all, as like people do come in with sensation loss that supersedes their motor deficits. But that would be like more those types of skills. And it'd be also from, if they did have sensory loss, it'd be to the pinky and to the other half of the ring finger. And then the recurrent branch of the median nerve, again, that'd be follow along with more of the median nerve injury, which we were referring to, which I referred to before. I hope that helps. If it doesn't, let me know.
Don made a good point in the chat too, that they really like to make the distinction between weakness versus full paralysis. I didn't really go fully into depth with that with these questions, but make sure you know that, like, okay, if there's radial nerve weakness, or like if there's extensor weakness, that could be a radial nerve injury proximal to the innervation of those muscles, or I'm sorry, distal to the innervation of those muscles. So you're not getting complete loss of function of those muscles, but you may be getting some weakness. Yeah, just make sure you review that too.
Thank you, Ashley. That's really helpful. Yeah, they definitely do like to do the whole lovely paralysis versus not. And a lot of times with compression injuries from overuse, it'll most likely be a weakness. Unless you wait, like, unless the person waited 50 years to come in or 30 years to come in to clinic. But even then, it's like a significant weakness, like a 1 out of 5 or 2 out of 5, not really a 0 out of 5 either, which is quite unheard of, honestly. Okay, another problem. So burning, tingling over the dorsal lateral aspect of the hand after wearing a fitness tracker, known motor deficits. What is the most likely injured structure? So this person does not have any motor deficits, and it's to the dorsal lateral aspect of her hand. Yep, everyone who's saying D is correct. Just to go over why it wouldn't be the ulnar nerve, would be, right, ulnar nerve would be the, every time I think ulnar nerve, just think, okay, it's gonna, for like sensation, it's gotta be at least the pinky and the half of the ring finger. And then, yeah, we can like talk about the dorsal part later, but like think, okay, it's gonna be the, those are the medial fingers. So like that one's an immediate, like, no. Median nerve, it's the palm, that would be the palmar aspect. So if you look at your hands, look at the palmar aspect, that's gonna be your median nerve, and this person has the numbness and tingling and burning pain to the dorsolateral aspect. So although that part can be a little tricky, just know that like radial's on top, so it literally goes with your extensors. And then that's where the sensation goes to. And then deep radial would have those motor deficits. And then since this person doesn't have any motor deficits, superficial radial nerve. Does anyone have any questions on that one? I know it can get confusing for the superficial radial nerve because it doesn't have any motor parts, but it's really just because it's supercutaneous or superficial. So that's why it's really cutaneous. Please explain. Oh my gosh, I didn't even see. I'm sorry. I honestly, I forget where that nerve goes. Oh my God.
That's
Sorry.
just cutaneous innervation of the forearm, essentially. It's like one of the small branches off of the brachial plexus.
Oh my gosh, that's right. Yeah, I think it does it does the lateral aspect, obviously, of the forearm, and then the um thank you. Thank you, Ashley.
Of course.
Yes.
I have a quick question. Is it
Yeah.
safe to are cutaneous and superficial interchangeable words? Sorry, I asked in the chat, but I'm pretty sure y'all were busy. Is that
Cutaneous means that it innervates the skin.
Mhm.
So they're not really interchangeable because you can say like something else is superficial to like something else. Like it just means it's higher in elevation, I guess, like from the inside to out. So
Mhm.
I think when I was saying that, I'm sorry if it caused any confusion. I just, in my mind, I think, okay, like where I know the radial nerve is on the body and
Mhm.
how it passes through, by the time it gets to where the superficial radial nerve is, it's more superficial and it only does cutaneous sensation. So that's just how I process
Okay,
it.
so there's no such thing as like cutaneous radial nerve. It's just because
No.
that's what I mean. I'm not confused about the answer. Just okay, I wasn't sure if that was
Yeah.
another form of saying superficial.
Nope. Yeah. This one's just called superficial radial nerve. And then make sure that when you guys are on your practical, I don't know what they're gonna have, but make sure if it's the different types of like the different branches of the nerves to be specific in what you are writing down, because obviously these are different nerves and they innervate different areas. So if you just say like just like if you group them all into like just median nerve or just radial nerve when it is like a deep or superficial, that wouldn't be correct. Just a tidbit from just a tidbit, that's it. Okay, so those are the deep muscles of the extensor compartment of the arm. Oh my gosh, I'm sorry. I don't know. I think I'm talking too slow. And I'm sorry. And I will try to go faster. But please tell me if anyone has any questions along the way. I'll let you um try to, okay, great. So now we're gonna do the deep muscles of the extensor compartment of the forearm. Here they are. You have to memorize them, draw it out, do whatever you need to do. I like doing things by abbreviations because that's how I was initially introduced to things. But a lot of times, right, they'll have very similar like originations and things. So even if you just like draw, what helped me was like drawing like the forearm, and I just like draw two lines as the forearm and have like and like break it down by category. So the deep muscles, I would just like draw like lines to kind of where they're from, kind of to where they go. And that's how you can kind of help. I don't know if you have difficulty grouping them together. Okay, so now we have the blood supply. Lovely artery here. Posterior interosseous. She does great work. Just know that that's what she does. What was the answer? Skylar, I'm sorry, I don't know what you're referring to.
Oh, sorry. I was just for the deep muscles with, oh, that's not a question. I'm sorry.
No,
That's-
you're okay. Yeah, this is just like the deep muscles of the forearm, of the extensor compartment of the forearm. You just gotta memorize them. APL, EPB, EPL, indices, and supinator. Yep, that's it.
Thank you.
Yeah, no problem. So yeah, the anterior interosseous artery, so that interosseous membrane that we were talking about before that lies between the ulna and the radius, it just kind of goes right along on it. And then it's right, if you think about like they're the deep extensors, so they're gonna be right basically like right on top of this interosseous membrane. So as the interosseous artery, the anterior interosseous artery is passing through, it could send these little cute branches off into the deep extensors, and that can give it its blood flow. And also, like, it makes sense that the artery is going to be pretty deep in the arm, right? Because it has got to be protected. It's protected by all these different extensors. Yay, now we're talking about the carpal tunnel. It's like, if it's not the first, it's like the second most common hand surgery, I think. So let me just, I think we have slides. Yes. Okay, great. So we have the flexor digitorum superficialis tendons. There's 4 of them. Great. FDS 4. And then there's the flexor digitorum profundus tendons, also 4. So we have 4 and 4 so far. I know I'm bad at adding. I like other math, don't like adding. We gotta get 4 and 4. And then we have the FPL, which is the flexor pollicis longus tendon. And there's only one of those bad boys that goes through the carpal tunnel, right? So altogether, there's 9 tendons and then the 1 median nerve, right? So if you think about it, like logically, without even thinking like, oh my gosh, like how does carpal tunnel happen? So if you're using your hands, say like a brand new activity, like one day, like, oh my gosh, I'm gonna start like knitting 200 scarves a day. Well, your wrists are gonna get all like the tendons are gonna get swollen, right? Because you're not stretching, you're just knitting whatever, what I said, scarves or whatever. So if those tendons are all getting swollen, then that poor little nerve in this little carpal tunnel is gonna get pinched. And that's how we eventually get the carpal tunnel types of syndrome. So I might have just given you this answer. And I'm sorry. I just love talking about carpal tunnel, but can we please all try this problem? I don't want to read it all again, but if I need to, let me know. Yay. Thank you all for putting C. Makes me happy. Yeah. Well, I think it meant like thumb, index, and middle finger. So it's grouping those 3 together. Cool. It could also be the half of the ring finger. But a lot of times people like, this is like the classic presentation will come in, numbness and tingling there. For carpal tunnel syndrome at the wrist, most people will not, I'm saying most because there's always like a case, but most people will not have numbness to, or like sensation problems really to their palm, at least in like the earlier stages, that would be more of a pronator teres problem. Fun fact. Let's all try this problem. So what explains why sensation of the thenar eminence is spared in carpal tunnel syndrome? This is really important. I love it. It's like Yappa clock. Okay. So yeah, it's not D. And I'm worried I have misled people now. So there's this what they call the palmar cutaneous branch of the median nerve, and it bypasses the carpal tunnel because like right before, can I go back? I don't know if, okay. No, we're gonna do this. Oh, wait. I don't know if it's in here. Do we have a picture? I need a picture. I'm gonna stop sharing for a moment, everyone. I'm sorry. I'm finding a picture.
For everyone that said D, I think some of the confusion was when we were talking about the radial nerve, we talked about the superficial radial nerve and how it provides cutaneous innervation to the thumb region, but that's on the dorsal aspect of the hand. When we refer to thenar eminence, that's on the palmar surface of the hand. So in this case, it would be talking about the palmar cutaneous branch of the median nerve.
Yes, thank you, Ashley. Okay, so I'm sharing my Chrome again. Can you all see my Google Chrome? This is what took me so long, was to literally just search that. But I like this picture, the one that's here. Oh my God, no. Oh my God, zoom. Okay, so this, I think, it's just like, I'm a visual person, so I think this is a visual for what Ashley's just saying. So see like the little purple, is there like a little thing? I don't know how to work Zoom anymore. The little purple that's on the left, that's like right here. And that kind of follows that sensory distribution of the superficial radial nerve. And then we can see here like the differences between median and radial. And then in our problem, okay, so the palmar cutaneous branch, so obviously that's not there, but say, oh my gosh, I'm gonna annotate. We're just drawing now. Okay, so say this is the carpal tunnel, like right here. Lovely. That's like where the flexor retinaculum is, and everything else is underneath of it. Fabulous. So when the regular median nerve like goes down and she goes under, and then she does all her stuff, right? But then there's a lovely branch, the palmar cutaneous one, that like splits off like right before it, and she goes above the flexor retinaculum, and that's what's providing sensation to the thenar eminence here. Whereas the regular median nerve, she's going to the fingertips, and she provides sensation there. She's doing, I don't know how it, like it splits different in everyone. Oh my gosh. Okay. That's like splits at the last minute. But the thenar eminence, she's getting provided by this lovely palmar cutaneous branch here. Does that help anyone? Please. I hope. I kind of like my drawing, not gonna lie.
I was just gonna say your drawing was really good.
I'm gonna screenshot it.
And
Okay.
also there's a picture of the palmar branch of median nerve in the chat box, so make sure to check it.
Yay, thank you. That's what you guys need. You guys need a real one, not one I just uncovered from my brain, but
I mean, your drawing is great.
thank you so much. Okay, so let's go back to, oh no, dear Lord. I don't know how to get rid of them. I got it. Okay. Okay. We're gonna move on from this problem now because we all got it. If anyone has other questions, feel free to like ask. This is really important. Abduction, you have to, if you do it yourself a couple times, you'll get it. And I like to think that like abduction, adduction are in like the same kind of plane of motion, like they're just going back and forth, and then extension, inflection, same plane, just back and forth the other way, and opposition, and is literally just like touching your pinky and other fingers. If anyone has any questions on that, like that one's a little straightforward, but sometimes it's confusing. So, oh my God, there's a question about it. Yay to all of those who can see. Yeah, so if it's coming, basically if it's coming straight at you, abduction, and then the rest are just process of elimination too. Good job. So we have lovely muscles of the thenar eminence, which was that muscle belly we were just describing, innervated by the median nerve, the biggest one that's affected in carpal tunnel syndrome. And there's three muscles: abductor pollicis brevis, flexor pollicis brevis, opponens pollicis. Make sure you just know which ones is like superficial to deep. But no, they're really all affected. And if you get really bad carpal tunnel, right, it's been compressed for so many years, this will be atrophied, and patients will not be able to even like touch their own pinky. So yeah. Now the hypothenar eminence, that is on the other side of your hand. It's on the pinky side, that side. And opponens digiti minimi, flexor digiti minimi brevis, abductor digiti minimi. So very similar. I can go back to that one, right? Very similar. It can get confusing. So just say it like 10 times to yourself for each one, and I think you guys can have it down. But again, no like superficial to deep, and each of them do little functions of their own. So make sure to keep that in mind as well. Now we have some arteries. We love them. Gotta supply the fingers somehow. So the deep palmar arch, made from the radial and ulnar artery. Superficial is made from the ulnar and superficial radial arteries. These are really just kind of, I feel like these are more facts to know. I try to think of ways to kind of associate it. That's, if anyone else has like tidbits to add about this, feel free.
I think the high yield thing to know for this is just that the deep palmar arch is going to be primarily contributed by the radial artery, and it's the like the ending point of the radial artery. And then the superficial palmar arch is primarily provided by the ulnar artery. So if you're gonna have like, an artery taken out, like if for some reason the radial artery is occluded, which palmar arch are you gonna see is gonna be occluded more, and it's gonna be the deep palmar arch.
Amazing. Thank you so much, Ashley. So we have some sheaths going on here. Oh yeah, does anyone want to answer this question? So the abductor pollicis longus and the extensor pollicis brevis. These form the lateral border of a very important structure. Yay. Oh my goodness. I love it. Oh my gosh, I don't know why. So yeah, that imports the snuff box, which is really important for, if this isn't, okay. I don't know if there's a question about the snuff box, but I'm just gonna talk about the snuff box right now because I love talking snuff box. Snuff box is really important. A lot of times people will fall. It's like the foosh injury, right? They'll fall on their outstretched hand, especially like if it's like says like icy and then they fall and they come in. They're like, it's like they don't have pain like anywhere else, nowhere else. They'll have the whole wrist exam, maybe a little pain somewhere else, right? Whatever. But those aren't as significant. Those are just like more contusions. But then they'll touch, like if you palpate over the snuff box, oh my God, the patients will be in so much pain. They're like, oh my God, ow. But if they come in right away and then they get an x-ray, you're not going to see it on an x-ray because right, it's so little and it's not really like you just can't see it. So either I think it's you send them to get a CT. I forget if it's with contrast or not. I'm pretty sure it's not with contrast. Nah, we'll just say no. I'm not sure. They'll get a CT so you can see it right away, or it's like they'll come back in a couple of weeks to get an x-ray. But by that time it's like you should be treating it. So most times when you have positive snuff box injury, you treat it as a fracture. And the snuff box has very poor vascularity. So that's why it's a risk for avascular necrosis, which obviously is not good because you need blood flow to the bone in order for it to heal. And you also need a good vitamin D level. If you don't have a good vitamin D level, it actually will delay your fracture healing as well. Yes, sorry, snuff box is scaphoid fracture. I don't know if I actually even said that. So let's all try this question, please. So the answer is D. So the Finkelstein test, does anyone know what the Finkelstein test, what oh my God, what clinical correlate is testing? Like what syndrome or tendonitis, I guess. The name, it's a fun name. Oh my God. That was not for that. So it's not far. No? Anyone? Okay. So the Finkelstein test for Dekroven's tenosynovitis. That is when they'll come in, very similar thing, like they'll have similar activities to like when you get carpal tunnel, even though they're not related in like any other thing except like the activities that may cause it. But they also call it new mom's thumb because moms or like parents or people who do like that type of lifting, that lifting when you're lifting. Oh my God. Sorry, I don't know if anyone just heard thunder from outside my window. If when they from that lifting position of lifting babies all the time. No, yeah, it's okay. No problem, Ashley. I'm just gonna yap about it. So when they lift up their babies, that the tendons, these two tendons, abductor pollicis longus and extensor pollicis brevis. Please remember which one's the longest and which one's the brevis because they'll probably try to trick you. Please don't let them trick you. It's abductor. I don't have any fun way to remember that. You just got to, they're kind of next to each other, right? So, but yeah, when they're lifting up the like babies or just doing lots of like that type of motion, it'll get inflamed and then they'll get like a cortisone injection and most times it goes away or with therapy, or if it's still really bad, they'll get a thumb spica splint just to keep it rested and neutral. Yeah. they could test us on diagrams. I'm not sure what type of diagrams you're referring to, but I think maybe someone else can help you with that. I'm gonna try to move on because I feel like we have more to get through, but okay. So I think we already kind of went over a lot of the snuff box already. So if you guys like, there's a nice little diagram here to go through the different orders and the bones of it. I think it's important to just know what artery goes through it and the nerve that goes through it. Does anyone want to try to answer the nerve and artery that goes through the snuff box? Yeah, radial artery. If it's on there, I'm gonna be sad. Okay, yeah, so oh my lord. Sorry, thunder. Oh my god. So yeah, and the superficial renal nerve, she's going through there. Good job, everyone. Sorry, I don't know if it was superficial. So can we all please try to answer this question? Lovely. Good job. I just saw y'all put it in the chat, so I'm gonna keep us moving because I tend to yap. Oh my gosh, if please, this is a great question. I believe you will all get this correct. I believe it. You can do it. My hearts. Yes. Thank you. I love you all so much. I love you all. I love that. Great. So now we kind of went over it. Someone answered it. So what artery is at risk now? Because it's in the snuff box with all the fun stuff. What artery is at risk of being injured? My heroes. I love you all. Fabulous. Oh my god, look at carpal bones. Yay! You have to memorize the order. Okay, escape, sorry. Escape was the only one. It's just the one that's most likely to be injured by the snuff box. So like when you have positive snuff box tenderness, like it's most likely just going to be the scaphoid. Just because it's closest to the I'm gonna let someone else answer that because I can continue to yap about that. But I'm just gonna tell y'all, memorize the carpal bones. You can make up your own mnemonic. You don't even need a mnemonic if you got it. Like, you know, but just gotta memorize it. Know which ones are the proximal versus distal row. Very important. I don't know if we talk about it at any point, but you can also get like acute carpal tunnel syndrome and acute like Guillain or ulnar nerve compression if you fracture one of these bones. So if you get a fractured capitate bone, right? If that's like pushed forward or anteriorly, right? What's that gonna hit? The median nerve. So then you're gonna get really like you'll say like there was I think they like got patient one time had it like squished between like two different objects and they came in, right? So much like that burning pain. It's not like, yeah, it's also sharp, but it's really burning, all the numbness and tingling, excruciating pain. It's because the capitate's fractured and it's moved and it needs to get fixed. Or even the lunate can also do that. The hamate is associated with the hook of a hamate injury. And that's more ulnar nerve, I believe. Okay. Well, those are really cute. Oh my gosh. Wait, so then since we didn't cover the yeah, so I think it's also the pisiform can also do ulnar nerve things. Okay, I would also like to talk about, if it's okay with you guys, oh my, Lord. Oh my God. Let me log in because God forbid it stays logged in. Okay. The ulnar nerve is also really important. And I'm going to pull up a picture of the ulnar nerve right now because there's two clinical correlates that go along with it. Distribution. It's called, if anyone knows the names of the two different ulnar nerve impingements, the clinical correlate names, and they would put in that chat, that'd make my day if you guys know the names of them already. The ones that can happen at I'm doing elbow down. I'm not doing the top of the brachial plexus today. Sorry, Klumpke. I'm not doing Klumpke today. Yes, Guion canal. Medial epicondyle is not a nerve problem. Yes, for cubital tunnel syndrome. Good job. I found one. Okay, great. We're back on Google Images, everyone. Lord. Okay. Let me get not my desktop. Okay, share. Yay, back to this. So cubital tunnel syndrome. Oh, zooming in. So it is the medial side of your elbow. That is where the cubital tunnel is. But that is not to be confused with medial epicondylitis, because medial epicondylitis is just basically the opposite of tennis elbow and lateral epicondylitis. And that is a tendon problem. We can talk about that in a bit if we want, but cubital tunnel, it'll be from like prolonged elbow flexion. So whatever can get you into that situation. So if you sleep like this, or with like your elbows flexed, or oh my gosh, or if you study and you're always sitting like this, yeah, you can get bursitis. Oh yeah, you can also get, oh my gosh, the elbow has so much. I love the elbow. I'm gonna keep going on tangents. Oh my God. But if you like lean on it a lot, right, you can irritate that nerve. A lot of things irritate the nerve. So if you start, I don't know, if you do too much bench pressing, I don't bench press, but like if you don't take care, like do stretching or whatever, right? So your nerve's gonna get irritated at the elbow, and then you're gonna get numbness and tingling to the, most times they'll feel it first most time it's to the palmar aspects of the little and the other half of the ring finger, but obviously you can lose sensation to the dorsal aspect of those of the medial wrist, right, and hand. But most time you'll feel like that really changed, because that's where you're always feeling things, right? And it's important to note too that since the ulnar nerve at the elbow, it innervates what muscle that allows you to, ulnarly deviate your wrist? Does anyone know? And I'll get back to your mallet finger question. I would love to go through the mallet and boutonniere and all that fun jazz. Yes, the FCU, flexor carpi ulnaris. That's important, right? Because if it's impinged here at the elbow, then, right, that's right when like the FCU's coming in place, and that's when they'll have deficits going that way, right? You can also get a claw hand. There's a difference between claw and there's like a hand of Benedict. So hand of Benedict is for median nerve, or no, not hand of benediction. Oh my God, hand of benediction. And it's like your hand's kind of just like this because you can't flex your fingers, and like they're just stuck straight, versus a claw hand, it's like this, and they're kind of like, oh my gosh, it's like that with these two fingers. They're like back, right? And that's because you can't basically straighten them because of a couple different muscles there. And great. So that's cubital tunnel. Does anyone have any distinct questions about just the cubital tunnel before I move on to Guillen's canal syndrome? Okay. I'm going to say that's a no. If you do, let me know. And if anything was unclear, like, well, please let me know. So Guillen's is when the ulnar nerve, I want to see if there's let me see if I can find a distinct picture for the Guillen's because that makes life a lot easier. But right when the ulnar nerve goes through Guillen's canal in the wrist, I don't like any of these. Oh yeah, great. And there's the hook of the hammock. Great. We love this. Okay. So Guillen's right through the wrist. Oh my God. We're gonna say that's Guillen's canal, like right there. Oh wait, you can't. I don't know if you can. Anyone see my mouse? I don't think you can, right? No. You can? Oh my God. That's great. So okay, where my mouse is right now, right? This is all Guillen's canal. We'll talk about the hammock in a second. But basically, if you get impingement at the wrist of Guillen or the ulnar nerve, that's going to be Guillen's canal syndrome. You, for the sake of this class, you will not see like the FCU problems there. So if they still have like normal FCU function, but they have pain, say at the medial side of the wrist with numbness and tingling to the medial two fingers, and or potentially then like a hamate fracture, which we call the hook of the hamate fracture, then that would be Guillen's. And it's also associated with bike riding because of how you hold the bike like this. And I think they also try to relate it to carpal tunnel syndrome. You can also get from a lot of bike riding too. It's just going to be how the patient presents, whether it's in the dorsal or not dorsal, medial or lateral aspects of the palmar aspect of the fingers, and causes wrist drop. Guillen's should not cause wrist drop because wrist drop should be from the radial nerve. This would cause claw hand. I'm going to show you all claw hand. Claw versus hand of benediction. Oh my God, look at that. That's kind of cool. That's kind of weird. Okay. This one, I like this one. There's your clunkies. Good job, whoever earlier. I just couldn't, there's just so much to yap about with ulnar and this. Hello, what is this doing? I like this claw hand. That one's a good one. That's literally what it looks like. And the patient cannot move they cannot move their fingers straight. And a big problem too with like, there's also like reconstruction surgeries you can get. So they'll move like a bunch of the redundant tendons in the place of it. So they'll be able to do that. But then they have to like go through therapy first because their fingers have been like this so long and they haven't been like passively stretching them with their other hand. So it takes a lot more work. Oh yeah, this is a good hand of benediction. So yeah, that's what the hand of benediction looks like. But sometimes I think when you first look at it, it's like, oh, they kind of look the same. But once you realize that, okay, it's because like these fingers can't flex for the hand of benediction, and then the claw hand, it's when they can't straighten their fingers basically because there's the oh my gosh, the ulnar nerves have been impaired. Does anyone have any specific questions about that? Because then I would like to move on to, okay, yeah. Are there two ways to get an ulnar nerve injury? Yeah, you can have multiple impingements. A common one is like, I don't know exactly like clunky per se, but a lot of people will get, it's what they call like double crush syndrome. So you'll have it, like, especially with like poor posture and stuff, you'll like get like a disc herniation or just like compression of one of the discs. And so you'll have a problem up there. And then you'll have like, from all this, either repetitive motion or whatever, you'll have problems at the elbow and the wrist, or the wrist, or all of them, honestly. So like triple crush syndrome, I guess, at that point. So that will obviously, if your nerves getting pinched in 3 different places or 2 different places, compared to 1, it's going to be even more painful or more debilitating. So for those cases, right, if a person's being seen in like a hand clinic and also in like the spinal center, the spine center will send them to the hand clinic first and be like, hey, if you can solve this problem with like a little surgery in your like wrist or elbow or whatever, that's a good first measure than getting like a spinal fusion. But yes, you can get multiple. Does that help? Great. Any other questions regarding this? This is like, I love this stuff, so I will continue yapping about it. It's like my inner broski, I think. So if anyone has any questions about this, I will happily answer them anytime.
Can I ask you a question about it?
Yes.
So for like the claw hand stuff,
Mhm.
so like would that be an injury just to the wrist? Or could we also see that further up? And like how would that look differently in a question?
Yeah, so you will see the claw hand in like really like progressive, not progressive, really like later stages of ulnar nerve impingement, both at the wrist and the elbow. It should appear the same way. The only thing that will differ, like they will be using to differentiate the hand versus the wrist of an ulnar nerve injury will probably just be like the FCU, like ulnar deviation, because of like the wrist motions that are there. But like the finger motions, right? The ulnar nerve goes all the way to the fingers. So no matter where it's pinched, it's going to still affect the fingers. But right, the FCU, I forget where exactly it attaches, but it's going to be before it goes to the Gans canal. And that's going to be basically the whole extent of the FCU tendon. So that's why that's different in the elbow versus the wrist. Does that